Hello, everyone. Warm welcome to all who joined this morning. My name is Chul Kim. I'm a thoracic medical oncologist and assistant professor at Georgetown University. I am honored to be your moderator for today's webinar, Clinical Trials for Thymic Epithelial Tumors, organized by Thymic. Today, we'll be exploring the field of clinical trials for thymic epithelial tumors, which is a key area with really profound implications for patient care in the future. Although rare, thymic epithelial tumors pose significant challenges in the clinic due to their complexity and diversity, and I think that really makes our conversation today both crucial and timely. And I'm honored to host 4 distinguished speakers today, each a recognized expert in the management of thymic epithelial tumors, and they have graciously agreed to share their insights and updates about the ongoing clinical trials being conducted at their institutions. To maintain a smooth progression of the session, we'll have a dedicated Q&A segment at the conclusion of all presentations. And throughout the talks, please do not hesitate to submit your questions via the chat function, or you can just voice your queries or questions during the Q&A segment at the end of the presentations. And your active participation is highly encouraged and valued. So we'll move on to the presentation, and it is my great pleasure to introduce our first speaker for today's session. Dr. Meredith McAdams is a staff clinician at the National Cancer Institute and part of the National Institutes of Health. Without further ado, I will now hand it over to Dr. McAdams. The floor is yours, Dr. McAdams.
Great. Thank you, Dr. Kim, for allowing me to present our clinical trials today. As Dr. Kim mentioned, I'm one of the thoracic oncologists at the NIH. And without further ado, I'll proceed with the presentation. So here's a brief overview of the clinical trials that are treatment related at the NIH for thymic epithelial tumors. We have 3 trials in total that are actively accruing. We have PT112, which is immunotherapy. I'm using a metallopyrophosphate conjugate, Bintrafusp Alfa, which is also immunotherapy phase 2 using a bispecific antibody, and Nabelimab, which is an immunotherapy in a phase 2 trial using a PD-L1 inhibitor. Today, I'll focus on primarily PT112 and also comment a little bit on Bintrafusp Alfa. So just generally, treatment options for thymic epithelial tumors, first line is a platinum-based chemotherapy, but many of these patients end up relapsing and needing second or third line or later line therapies. The options are really single agent chemotherapy or biologic therapies, and the response rates vary depending on the biologic or the single agent chemotherapy, but can range from 20% to 38%, but these come with toxicities. Immunotherapy is an option for some patients with response rates ranging from 20 to 35. 20 to 25 is more realistic, but many of these immune checkpoint inhibitors aren't able to be given in the setting of autoimmunity, and they come with immunotoxicity. So the goal is to create new treatments with immunotherapy or immunomodulatory drugs, primarily to improve overall survival, but also to improve clinical durable benefit, so maintain responses over a period of time. So to jump into the first trial, it's PT112, and to give a little background as far as the mechanism of action, what it is, it's a pyrophosphate platinum conjugate, and despite it kind of sounding like cisplatin or carboplatin, it actually is a unique compound that reduces the toxicity that you see with standard platinums. So with carboplatin or cisplatin, you think of nephrotoxicity, so injury to the kidneys or neuropathy, which is less common in this using this compound. And then a little bit about how it works. It's not your traditional immunotherapy with an immune checkpoint inhibitor. It actually induces immunogenic cell death by releasing proteins in a damage-associated molecular pattern. It activates various immune cells, within the body, and then provokes your own immune system from attacking cancer cells with your adaptive immune response. What's also interesting about this compound is that many patients develop resistance with chemotherapy. And commonly, this is a DNA repair-mediated drug resistance, and PT112 isn't actually impacted by those resistant pathways. So what do we know from the clinical data for PT112? So this is from a phase 1 trial, and phase 1 trial is primarily looking at toxicity, tolerability, and finding the appropriate dose. But phase 1 trials generally are given for various solid tumors. These specific patients, there were 66 enrolled. 2 patients had thymoma. And then the dosing was variable based on which dose level they were on. The schedule was on days 1, 8, and 15, which is the same for our trial. Patients that had at least one adverse event, so a side effect, about 74% had at least one or more, but that's pretty common when you're seeing immunomodulatory therapies, immunotherapy, or systemic chemotherapy. Most common side effects were fatigue, low blood counts, some neuropathy, and nausea, but this was generally low grade and pretty mild. And then notably, the phase 1 trials aren't necessarily designed to assess response rates, but can give you a general sense of clinical activity. And so 3 patients in this trial demonstrated a partial response. And of note, all 3 of these patients had thoracic cancer, and this response was durable, so more than 6 months. So to go into a little more detail about the thoracic cancer patients in this phase 1 trial. So this is a waterfall plot, and I know there's a lot going on, especially if you're not really used to these types of plots, but on the x-axis, there are bar graphs for each patient. So there are 8 patients in all that had thoracic cancer in this phase 1 trial. And then on the y-axis, that is measuring the degree of tumor growth or degree of tumor shrinkage from the patient's best response to their baseline scan, or just their best response from baseline scan. So what you're seeing, this dotted line up here, that's plus 20%. Above it is considered progressive disease. And then technically, when we're looking at tumor volumes and shrinkage or growth, this plus 28% to minus 30% is all calculated as like a stable disease. And then anything less than 30% is in this particular graph is a partial response. So as I mentioned in the previous slide, 3 patients had a partial response, and those are these patients right here. This patient also had on one scan a partial response, but for our calculations and reporting, the responses have to be documented at 2 time points. And so this patient didn't technically have a confirmed response, but did have greater than 30% shrinkage, at least on one scan. And then the other thing I wanted to comment on is that the 2 patients enrolled in the phase 1 trial who had thymomas, one had a partial response, and then as you can see here, another one did have tumor shrinkage, although the response wasn't greater than 30%. And then in this patient, all the way to the right, I wanted just to show CT scans of the response. So this was this gentleman's baseline scan. This was a scan after 2 months of treatment. And you can see disease that previously was in the right thoracic cavity is decreased in size. And then a year later, despite stopping treatment, he continued to have a response. And this is, what we want and what we are aiming for when we're developing immunomodulatory drugs or immunotherapy, in that we see decrease in size of tumor or tumor stability, and also that these responses can be maintained over time, despite maybe stopping treatment or interrupting treatment. So that's, really our aim in developing these types of agents. And then as far as the rationale for why we are using it in the thymic epithelial tumor patient population is that overall treatment is relatively well tolerated. And then also that this is an immunotherapy option that's technically coined immunomodulatory, working by immunogenic cell death, and doesn't come with the same toxicities as an immune checkpoint inhibitor in our thymoma or thymic carcinoma patients. So patients who have active autoimmune diseases or have already progressed on an ICI, an immune checkpoint inhibitor like Pembro or Keytruda, this may be a good option for those patients. And then also what I mentioned kind of in the first slide with overview is that PT112's mechanism of action isn't impacted by common ways tumors become resistant to cytotoxic chemotherapy. And then also, what I had just presented in the clinical data as far as, activity within thymoma patients and lung cancer patients. So as far as the study design, it's a phase 2 single treatment arm, meaning all patients get treatment. Eligibility, you have to have received at least one prior line of therapy. The disease has to be active, progressive, and measurable. Patients generally have to have a good performance status or function well and have overall normal organ function and normal labs, just generally speaking. And like I mentioned earlier, history of autoimmunity or ICI aren't automatically exclusion criterion. So this is the study schema. PT112 is given on day 1, 8, and 15 of a 28-day cycle. Imaging is done after every 8 weeks, and there are optional biopsies. And then treatment is continued until toxicity or until disease progression or the side effects become unmanageable. So the primary endpoint for the study is determining the objective response rate, and then also looking at duration of response, progression-free survival, and overall survival. So this is the information just for completeness that you all can reference if you want to look into this further. And then the second drug that I wanted to briefly touch on is Bintrafusp alfa. And basically the background kind of goes through that immunotherapy activates the immune system to help kill cancer cells. So, and with more experience and focused investigations, TET patients can be managed with close and careful monitoring as they have increased risk of immune-related adverse events. And so Bintrafusp alfa aims to target 2 pathways within the immune activation cascade, and that is going to be TGF-beta here, and then the PD-L1 axes. And then, like I mentioned, it leads to activation in 2 separate pathways. And then why we are using this with epithelial tumors is that it has shown safety and clinical activity. The side effect profile is generally the same as immune checkpoint inhibitors, except there are 2 notable differences that targeting TGF-beta can cause reversible skin eruptions, so keratoacanthomas, and some mild mucosal bleeding, so a little bit of bleeding from the gums or from the nose, but not clinically significant. And then why I use this in thymic epithelial tumor patients is that when you look at tumor samples from prior chemotherapy, or baseline tumor samples were taken from these patients, there was increased TGF-beta expression, and this was associated with worse clinical outcomes. And then lastly, in the phase 1 trial, there was a heavily pretreated thymoma patient with a large disease burden who was treated with Bintrafusp alfa and had disease stabilization without an increased risk of immune-related side effects. So the study design is similar to PT112, at least a prior line of platinum-containing therapy, progressive measurable disease, overall good health status, but here you can't have a history of autoimmune disease or prior immune checkpoint inhibitor. And then again, it's a single treatment arm. Patients get treated once every 2 weeks until a disease progression or side effects. Restaging's after every 3rd cycle, and then the endpoints are overall the same. This is a little bit more information about Bintrafusp alfa. And then again, the 2 studies that we're actively enrolling that I spoke about are PT112 and Bintrafusp alfa. We also have Avelumab, which has been in the pipeline a little bit longer. And then we have a natural history and tissue procurement study that's a research protocol only. It's not an active treatment protocol. Dr. Arun Rajan is the principal investigator. And I'd like to thank Shannon Swift, Chris, and also Susan for their help. And also thank you to our patients and their families.
Thank you very much, Dr. McAdams, for your presentation. Now we have the privilege to welcome our next speaker, Dr. Dwight Owen, an associate professor of medicine at the Ohio State University James Comprehensive Cancer Center. Dr. Owen, we look forward to your presentation.
Great. So thank you to ITMIG and everyone for the opportunity to discuss combination targeted therapies and immune therapies today with the focus on our clinical trial of Pembrolizumab and Sunitinib in patients with metastatic or unresectable thymic carcinoma. It's really a privilege to be able to speak at this group, and I recently was just able to join this group and looking forward to collaborating. I will disclose that I have research funding from multiple groups, including Merck, which has funded the investigator-initiated study that we'll talk about today. I did want to go through some background and rationale for our trial before getting to the specifics of our study, and I promise I'll try and do my best to stay on time. So as Dr. McAdams already mentioned, really the NCCN guidelines for first-line treatment are primarily chemotherapy for patients with both thymomas and thymic carcinomas. However, in the second and subsequent lines, there are targeted therapy agents, including everolimus, which I won't be discussing today, but I will be focusing our discussion on sunitinib and lenvatinib, the VEGF multikinase inhibitors. When we think about the multikinase inhibitors, we think about the first, second, and third generations, which of course have implications in terms of selectivity for VEGF, with the first and second generations being unselective and the third generation being selective. Most importantly, the potency, which has a direct impact on both the efficacy and of course the toxicity profile of these agents. And perhaps very importantly, other targets that some of these agents hit. The more selective that the agent becomes, the less other targets are hit, and the relevance of those targets is not clear, at least at this point. So first, I'd like to talk about sunitinib. This was a study led by the NCI by Dr. Thomas. This was an open label phase 2 study, and I'd like to thank Dr. McAdams for covering the waterfall plots because we will see a few of those. This was a 41 patient study. It was both thymic carcinoma, which I indicate by TC, and thymoma patients. And the response rate was 26%, but although that was only in the thymic carcinoma patients, which if you look at the waterfall plots, it's the waterfall plot on the left, which indicates that more patients with thymic carcinoma saw a decrease in their tumor lesions compared to those patients with thymoma. There's a really impressive duration of response, which is for those patients who had a response, how long did that response last? And a median progression-free survival, which was actually quite similar between thymic carcinoma and thymoma. And a median overall survival, which was not reached at the time of publication in the thymic carcinoma patients, which again is very impressive, given that these patients typically were treated with chemotherapy or other limited options. There are significant toxicities with sunitinib, and I would point out that the dosing used in this study was 50 milligrams daily on a 4-week on, 2-week off dose, which was one of the first doses studied in renal cell carcinomas and other tumors. And it resulted in treatment-related adverse events in over 2/3 of patients. Many patients, 65%, required a dose reduction, and about 1 in 5 patients had to discontinue treatment due to a treatment-related adverse event. So even though this is a pill and is well tolerated in many settings, it is still associated with significant toxicities. I'll just briefly mention that Dr. Thomas also led a blood-based exploratory analysis looking at specific immune cell subsets that seem to be associated with benefit. Although this was an exploratory analysis and these were small numbers, there seemed to be some impact of sunitinib on relevant immune cell subsets, which we'll see is relevant in combination strategies. Turning now to the phase 2 Remora study led by the Japanese group of lenvatinib. This was a 42 patient study, which is the largest study to my knowledge, specifically focusing on patients in thymic carcinoma. All patients received lenvatinib 24 milligrams, which is the full dose, but as we'll see, all patients also required dose reduction. Almost 40% of patients, as you can see in the top right, saw a significant decrease in their tumor burden, with a duration of that response approaching 1 year, and a median survival which was not reached at the time of publication. The bottom right is a swimmer's plot, so that is the time that each patient is on treatment. But this plot actually also provides the different colors, which are different dose levels. And as you'll see, almost all patients by 3 months had to be dose reduced from 24 milligrams, all the way down in some cases to 4 milligrams. And you can see that some of the patients who are on treatment the longest were on 4 milligrams for quite some time, which proved that even at that dose, there's efficacy. I will note that almost no provider that I know of would start patients at 24 milligrams. It's a very high dose. We typically start at much lower doses. And that's because of the toxicity profile of this drug. We know that hitting VEGF is associated with high rates of hypertension, of rash, which is palmar-plantar erythrodysesthesia, the PPE, as well as decrease in platelet counts. About 17% of patients had to discontinue study. And again, as I mentioned, 100% required dose reduction. So this is a drug that can be very difficult to tolerate if given at the full dose. I'd now like to turn to our study, but first to point out the recently published caveat study. This is a very exciting phase 2 study of avelumab, which is an immune checkpoint inhibitor, plus axitinib, which we saw was a selective VEGF multi-kinase inhibitor, which is a pill. This included 32 patients. Most patients were thymic carcinoma. All patients had progressed on platinum chemotherapy. I will point out that about a significant amount of patients had received not one, but 2 or even 3 lines of prior treatment. And interestingly, patients who had received prior sunitinib or ramucirumab, which is a different type of VEGF inhibitor, were permitted on this study and represented a fair number of patients. I'd also point out that treatment beyond progression was permitted. So there's a lot of data on this slide, but I'd just like to highlight that the responses occurred in over 30% of patients with a disease control rate, which is at least stable disease or response in over 90%. On the bottom right, this is another version of a spider plot showing that the patients who had not received prior VEGF treatment were patients that seemed to have done better overall with a greater decrease in tumor size and longer duration of benefit. And that held up in various efficacy endpoints that we follow in terms of duration response, progression-free survival, and overall survival. And lastly, I'd point out that the PD-L1 expression did not seem to correlate with response, which is somewhat different than what we see in other tumors, especially lung cancer. Toxicity profile somewhat better in terms of the VEGF toxicities, although the same toxicities in terms of hypertension and rash continue to show up. And here, now that they're being combined with a checkpoint inhibitor, we do see the development of serious immune-related adverse events in a subset of patients, including pneumonitis, polymyositis, including one grade 4 event, which included myocarditis, and one patient who went on to develop a T-cell lymphoblastic leukemia, which, although extremely rare and uncommon, is something that we've seen when these checkpoint inhibitors are used in other patient populations. I do want to give a brief mention to Dr. Pata, who was, of course, a big part of this group, who presented this data, which is a multi-arm study combining vorolanib with nivolumab. Vorolanib is another type of medication that's designed to be similar to sunitinib, although slightly better tolerated. There is a group of patients that will be enrolled with both thymic carcinoma and B3 thymomas. Early data were presented at the ITMID meeting a few years ago, including 3 patients with thymic malignancies, 1 with thymic carcinoma, and 2 with B3 thymoma. And these patients did seem to have some benefit, with a deep benefit in one of the patients with B3 thymoma. I would note that vorolanib did run into liver toxicities, and so the dosing moving forward is 200 milligrams and not 300 milligrams. Finally, just in the last few minutes, I'd like to highlight our study, which is pembrolizumab and sunitinib in patients with thymic carcinoma. This is a single-arm phase 2 study, meaning that all patients receive the combination treatment. Accrual is ongoing here at Ohio State, and we just recently, after years of efforts and delays from the expected events of the last few years, we were able to open at Moffitt and Indiana University under the leadership of Dr. Patrick Lair. One unique aspect of our study is that there is a sunitinib run-in, meaning that patients receive 1 cycle of sunitinib before the combination, pulling out some of that data from Dr. Thomas's study that sunitinib does seem to lead to an altered milieu of the immune cells that might make the immune system more likely to respond. We are conducting research biopsies after that brief cycle to evaluate that and to prove that that's the change that we're seeing, followed by the introduction of pembrolizumab at that point. I'd also like to point out we're using the 2-week on, 1-week off schedule, which seems to be a little bit better tolerated than the 4-week on, 2-week off that was initially studied. The primary objective of the study is how well the combination works. And we're also looking at other objectives, including safety, toxicity, progression-free survival, and overall survival. And the on-treatment biopsy is to support the exploratory objective of whether sunitinib pretreatment alters the immune response in the tumor microenvironment. I'll just briefly put up key inclusion and exclusion criteria, which are specific mostly for safety. Uncontrolled hypertension, for instance, or ejection fraction issues would be high risk for sunitinib. At this point, we actually are not permitting patients who have had prior sunitinib, although patients who have had prior checkpoint inhibitors are permitted in the safety run-in before we open to the full phase 2. And then typical of most checkpoint inhibitors, myasthenia gravis patients are not able to enroll in the study currently, although I really like Dr. McAdams' flexibility in this. And I think that one of the things we need to do is figure out ways to have access to trials for those patients. Here's a list of ongoing combination studies just for completeness. The Picati trial combines lenvatinib with pembrolizumab. This is only available currently in Europe, in Spain, Italy, I believe. Our study, which is available at Ohio State, Moffitt, and Indiana, and then the vorolanib study I listed here as well. Lastly, I think there are really important questions, including which VEGF multikinase inhibitor is the right, or is it a TKI, or is it a monoclonal antibody? We have to take into effect that there's a different toxicity profile with these agents, which can limit their ability to be used in the clinic. Are there good biomarkers for these patients? Is there a right sequence, or perhaps a combination? In other cancers, we give immune therapy with chemotherapy. Is that something that we should be considering here? Bringing it to an earlier line of therapy, all the studies that we've talked about were post-chemotherapy. And then I think a real unmet need is anticipating, mitigating, and managing the development of immune-related adverse events, especially in patients with thymoma, where this seems to be more common than in patients with thymic carcinoma when we use checkpoint inhibitors. So thank you very much for your attention. I added the study email here at the bottom. It's thoraciccrcs@osumc.edu. I really appreciate your time and looking forward to the question session later. Thanks very much.
Thank you, Dr. Owen. Now I'd like to introduce our next speaker, Dr. Chris Nabel. Dr. Nabel is a attending physician in medical oncology at Mass General Hospital and instructor of medicine at Harvard Medical School. Dr. Nabel, the floor is yours.
All right. Thank you, Dr. Kim, and thank you to ITMIG for organizing this event today. I'm going to be talking about a new investigational agent called IMC F106C, which is a little bit of a mouthful, and I'll shorten it to F106C throughout my talk. These are my financial disclosures, which have no connection to the diagnosis or management of thymic epithelial tumors. And I'd like to start out by talking about the biomarker that this investigational agent targets, and a biomarker called PRAME, which stands for Preferentially Expressed Antigen in Melanoma. And as the name would suggest, it was identified over 20 years ago as an antigen that was preferentially expressed in melanoma as opposed to normal tissues. And in more recent years, there's been an increased interest in identifying and using this biomarker to identify other malignancies. Within the past few years, there was a very nice study from Taniguchi and colleagues demonstrating the selective expression of PRAME within thymic carcinoma, specifically with squamous differentiation. What you can see here from this immunohistochemistry is brown staining of the PRAME antigen within thymic squamous cell carcinoma with compared to other thymic epithelial tumors, type A and B thymomas. And in their study, they found that all 17 of the thymic carcinomas with squamous histology that they evaluated were positive for the PRAME marker, and also positive for other markers commonly seen in squamous thymic carcinoma, such as c-KIT and CD5, and that these rates of PRAME positivity were relatively lower in thymomas as well as normal thymus controls. And so that leads to the formulation of a PRAME-targeted bispecific T-cell engager, which is really the formulation of IMC F106C. So it is a bispecific antibody that has two domains. One domain is engineered to bind to PRAME on the tumor cell. And the way that this works, the binding domain is actually an engineered T cell receptor fragment that binds PRAME peptides presented on a specific HLA allele. So this is an HLA restricted T cell receptor fragment. The other domain of the bispecific antibody recruits CD3 positive T cells so that they can be recruited to the tumor cells and induce an anti-tumor immune response. And so this is really the mechanism of action for this biomarker-directed bispecific T cell engager. There has been an initial study of F106C, primarily a phase 1 safety study that was reported at ESMO within the last year. Within this study, key eligibility criteria included patients testing positive for the HLA A0201 allele, which is the HLA restriction for the TCR fragment that I mentioned. The safety study allowed for many different advanced solid tumors that were known to be positive for PRAME by immunohistochemistry based on historical studies. Within this study, patients received weekly IV infusions and received assessment with CT scans every 9 weeks. The primary endpoint was to determine the maximal tolerated doses with safety endpoints as the secondary endpoints. And the schematic on the right just gives you a sense of the dosing escalation. Overall, F106C was tolerated fairly well. For bispecific antibodies, a major class of side effect is cytokine release syndrome. And the investigators found that while approximately 50% of patients had cytokine release syndrome, these events were all low grade, grade 1 and grade 2, with no grade 3 or higher CRS or cytokine release syndrome events observed. This plot or this graph shows you a series of waterfall plots showing the best overall response, nicely outlined by Dr. McAdams and Dr. Owen in the trials that they presented as well. Here broken down by the respective primary solid tumors that were enrolled within this safety trial. And what you can see is a mixture of partial responses and stable disease, indicating a promising initial signal within this study. So this basically sets the foundation for ongoing evaluation of the safety and efficacy of F106 as a single agent and in combination with checkpoint inhibitors in a much larger expansion study. So the expansion study consists of both phase 1 and phase 2 portions. The phase 1 aspect is, again, to really evaluate maximum tolerated dosing and recommended phase 2 dosing of F106C as a single agent. Here, primary endpoints are incidence and severity of adverse events, with secondary endpoint being the best overall response. The phase 2 portion of this study involves really assessment of efficacy of F106 as a single agent in selected advanced solid tumors, with a primary endpoint of best overall response, and secondary endpoints being progression-free survival, overall survival, duration of response, presence of anti-drug antibodies, and drug pharmacokinetics. Select inclusion and exclusion criteria that I'd like to share. So in terms of inclusion criteria, this study enrolls PRAME-positive solid tumors. There are many solid tumors that are positive for PRAME, and so there are several arms based on those individual tumors. There is a basket arm that allows basically all known tumors that are historically positive for PRAME to be treated with single agent therapy. And so this is the basket arm for thymic carcinoma. F106C is only available as a single agent and not in combination with any additional checkpoint inhibitors, which are only studied in combination in other select solid tumors. Because the F106C bispecific antibody includes a T cell receptor fragment, patients need to have a positive HLA-A0201 allele, and this can be tested centrally. And lastly, patients need to be relapsed or refractory to standard of care treatments. With respect to exclusion criteria, I'd like to note that prior immunotherapy is not in and of itself an exclusion criteria. So having received prior Pembrolizumab or Keytruda is permitted on this study. However, patients who had prior immune-related adverse events that were serious, that is an exclusion criteria. So adverse events requiring immunotherapy discontinuation, active autoimmune disorders requiring ongoing immunosuppression beyond sort of a low basal level, or any active immunosuppression within the last 4 weeks are all exclusion criteria for this study. In terms of the study logistics, the dosing scheme generally is similar to what was done in the phase 1 study, meaning weekly infusions over a period, an initial run-in with increasing dose over the first 3 weeks, and then maintaining subsequent dosing as indicated by dosing levels, depending on the patient's cohort. Thereafter, again, tumor assessments are every 9 weeks. Because this is a phase 1, phase 2 study, it's being run at MGH out of our phase 1 clinical trials group. And so our site investigator is Dr. Oladapo Yeku, who has been treating our patients internally at MGH. He is a GYN oncologist, and there are several other cohorts that involve accrual of GYN oncology patients. However, I'd also like to note that this study is available at over 30, at 30 total study locations throughout the United States and the United Kingdom. And so there is somewhat greater geographic flexibility here. So just to summarize, I think the advantages of this study is that it allows for prior immune checkpoint blockade and standard of care Pembrolizumab for patients with advanced thymic carcinoma. I think bispecific T-cell engagers are intriguing given the rates and complexity of immune-related adverse events in thymic carcinoma, and it's possible that there might be an improved safety profile over immune checkpoint blockade. And I think an additional advantage is that there are numerous sites available across the United States, as well as the United Kingdom. Notable disadvantages are that this trial option will only apply to a limited subset of patients with thymic carcinoma and not thymoma. And additionally, patients need to test positive for the HLA-specific allele that I've mentioned, which is present in about 40 to 50% of the general population. This clinical trial is an intensive time commitment for patients involving weekly infusions and intensive monitoring, given the concern for cytokine release syndrome as an adverse event. And lastly, as this is an early phase 1, phase 2 trial, the determination of safety and efficacy is ongoing, which I think really contrasts with other types of trials, particularly as Dr. Owen previously highlighted, in terms of combining other agents that have known efficacy as single agents. So if you have any particular questions about this study, feel free to reach out to me. I have my email here. If you'd like to get more information on this study, I encourage you to visit clinicaltrials.gov and use the NCT numerical identifier. And thank you all for your time.
Thank you, Dr. Nabel. So now it is my honor to introduce our final speaker, Dr. Annemarie Shefford. Dr. Shefford is a radiation oncologist and then and assistant attending at Memorial Sloan Kettering Cancer Center in New York. Dr. Shepard brings a unique perspective to our discussion today. Unfortunately, she couldn't join us in person for this session, but she has kindly provided video recording of her presentation. And Dr. Shepard, is eager to engage with your questions regarding our clinical trial. So we encourage you to send your questions and comments through the chat function during or after her presentation. And now let's proceed with Dr. Shepard's recorded presentation.
Hi, my name is Annemarie Shepard. I'm a radiation oncologist at Memorial Sloan Kettering Cancer Center. And I'm very grateful for this opportunity to talk about this interesting radiation technique that's used to treat the pleura in patients who have pleural metastases from thymic malignancies. So this is a phase 2 study looking at hemithoracic intensity-modulated pleural radiation therapy, what we call IMPRINT, for these patients. So just some background. As far as our thymic patients are concerned, pleura is the most common site for recurrence and progression. And the management of pleural recurrences in patients with thymic malignancies is challenging. Currently, our paradigm is to treat patients with surgical resection. Surgery is the mainstay of treatment for thymic malignancies. So patients get these pleural metastases resected until further resections are considered a little too risky. Then at that time, the patient moves to systemic therapy. And we use targeted radiation for symptomatic disease. So the idea of using IMPRINT is that treating the pleura with radiation in a safe way can potentially help to delay any pleural progression. As far as how patients do when they have pleural metastases, so this is a study of 72 patients who were diagnosed with thymic malignancies with pleural metastases. And this graph shows how each patient did. All the patients had surgery. Most of them had thymectomy and pleurectomy. And more than half, so 63% of patients eventually had progression in their pleura from their thymic malignancy. And what you can see here in these triangles for each patient is a time of progression. So even after surgery, the risk of progression for patients with pleural metastases is relatively high. And so the hope here is that we can use radiation to prevent or delay the development of this pleural progression. So what's the precedent for doing pleural radiation? Well, it does come from the mesothelioma literature. At MSK, we do IMPRINT standardly in some of our mesothelioma patients. And we showed that in mesothelioma patients, this technique is relatively well tolerated. The main risk from this type of treatment is something called radiation pneumonitis, which is inflammation in the lung from radiation that can happen months after the radiation's done. And in this study, there were 22 patients who developed grade 2 pneumonitis. So grade 2 is pneumonitis to the point that patients need steroids for treatment, and 7% developed grade 3 pneumonitis, so a little bit more severe. But all patients responded to steroids, and there were no grade 4 or 5 pneumonitis cases. So the issue, though, is that mesothelioma patients are very different from our thymic patients. Mesothelioma patients tend to be older, more frail, and the mesothelioma is more aggressive than a thymic tumor. So the question is this technique just as well tolerated in our thymic patients, which is a different population compared to the mesothelioma patients? So we hypothesized with this study that patients with pleural metastases from thymic malignancies, that IMPRINT will result in acceptable toxicity rates. And so the primary objective is really this grade 3 or higher radiation pneumonitis occurring within 4 months of finishing treatment. We will also look at other secondary objectives like other toxicity. We'll look at progression-free survival, patterns of failure, overall survival, and patient-reported outcomes. And we plan to accrue 36 patients over the next 4 years. So who are the patients that we're looking for? So these need to be patients who have been diagnosed with a thymic malignancy, so thymoma or thymic carcinoma. They need to have pleural metastases, and the pleural metastases has to be just surrounding one lung. So there can't be any contralateral lung pleural metastases. There also can be no extrathoracic metastases. So the pleural metastases really need to be limited to an ipsilateral pleura. Patients need to have good performance status and good lung function. Because the main risk is the radiation pneumonitis, we are excluding patients who are on oxygen. There's a theoretical concern that myasthenia gravis patients may be at slightly increased for pneumonitis, so we want to make sure that this treatment and protocol is safe. So right now we are excluding these patients. Because the pleura dips down into the abdomen region, patients need to have both of their kidneys. Prior radiation is allowed as long as we can generate an acceptable radiation plan. Patients cannot have a prior pneumonectomy, and they can't have other significant medical issues that can put them at risk for pneumonitis. So if there's any radiation oncologists in the audience, here are some radiation specifics. So ideally, we would do this with proton therapy. Proton therapy is a slightly more targeted form of radiation, and we have the ability to target the pleura and spare the lung and the heart more easily with proton therapy. So ideally, we would treat patients on this protocol at the New York Proton Center with proton therapy. However, if patients can't get proton therapy for logistical issues, IMRT is allowed, and that is also what we use standardly for our mesothelioma patients. The radiation dose is 50.4 gray and 28 fractions. This technique is a very specialized technique. So not only the radiation oncologist, but the whole physics and dosimetry team need to have a lot of experience with this type of technique. Because if it's done incorrectly, patients can be at high risk for severe pneumonitis and even potentially fatal pneumonitis. So it is of utmost importance that the patients get planned in a very specific way. So we have a contouring atlas that we've developed to determine how to generate the targets. Pre-treatment review is required for all cases, and there are very strict dosimetric constraints, so dose tolerances for each of the organs that must be met during the radiation planning to deliver this treatment. Here's the general flow chart. All of this stuff is pretty much standard of care. We'll follow patients in a very standard of care way. We'll be getting pulmonary function tests before treatment and then also in follow-up. So I wanted to just show one of the cases that we've treated this way. This patient was actually treated right before the protocol opened. He's 36. He presented with chest pain. A CT scan revealed this anterior mediastinal mass, as well as some left-sided pleural metastases that you can see here. He was staged as a stage 4A WHO B2 thymoma. He received a neoadjuvant chemotherapy, so here's the response that he had from the chemotherapy, and then he had surgery. He had a total thymectomy, mediastinal dissection, pleurectomy to remove the pleural nodules, and then the tumor was invading into the left upper lobe, so he had a lobectomy. The pathology revealed a 10.6 centimeter tumor. It was involving the lung. Those pleural nodules were positive for thymoma, and he had negative but close margins. So he was a great candidate for this IMPRINT technique. He was young, he was fit, he wanted to be aggressive to really reduce his risk of recurrence as much as possible. So this is his radiation plan, the proton plan. We treated the left hemithorax. The dose was to 50.4 gray. So this is like a kind of a heat map showing where the radiation is going. We set the bottom limit at 45 gray. What you notice here is that the lung is nicely spared from the radiation. The right lung is completely spared, and the left lung, we have a nice donut hole here sparing the lung. Additionally, the heart is spared as well as possible. And again, if there's any radiation oncologists in the audience, here are the dosimetric constraints that we had for this case. So the lung V20 was 28%, mean lung dose 13 gray, right lung V5 was only 8%, and the mean heart dose was 22 gray. So given the large volume, these are pretty good dose statistics for this plan. So how did he do? He tolerated the treatment well. He did have expected fatigue. He had some mild nausea. And then 2 months after completing IMPRINT, he did develop grade 2 pneumonitis. He did respond very well to steroids. Here are his scans after, so this is his scan post-surgery after his left upper lobectomy. So you see that his left lung is smaller. Then after IMPRINT, there is some scar tissue that does develop in the left lung, but clinically he's doing very well. So he's about 1.5 years out from treatment. He's back to the gym and working. He just had a baby. So clinically he's doing well. He hasn't recurred. Granted, it's still, early 1.5 years, but he tolerated the treatment really well. And so I think he was really, an ideal candidate for this type of treatment. So if you would like further information, clinicaltrials.gov, here's the identifier. Also on clinicaltrials.gov is my office number. If you have any patients that would be interested in learning more about the study. I'm really sorry that I can't be there to participate in the Q&A session, but I'm really interested in hearing your questions and eager to get any comments or feedback. So please put them in the chat and the organizers will reach out to me and I'll get back to you with all your questions. Again, thank you for this opportunity.
All right, thank you very much, Dr. Sheffer. Now we will proceed to the Q&A session, and I see a question in the chat for Dr. McAdams for PT112. There seems to be a good response in some of the Thymoma cases. And what are the features of those cases? If there's any information available, could you share that with us?
Yeah, that's a really important question and an important point to tease out. I suspect there isn't a specific salient feature, but probably multiple things going on. So in our study, we're looking at biomarkers for response both in the blood, and we have optional paired biopsies prior to treatment and while on treatment. So in those patients, we'll be able to better understand the tumor biology and some of the immune activation features. Specifically for these two patients, one went into a little bit more detail in the phase 1 study, but we don't have specific details on patient or disease characteristics. We do know the patient was 31, he was male, he had metastatic thymoma, he had gotten 4 lines of cytotoxic chemotherapy and was ICI naive. And then his response, scans after 1 month showed a decrease in size of tumor. After 2 months, it was also decreased. And then 4 months into treatment, he had a further decrease to -61%. And then ultimately, after 5 cycles, treatment was held for neutropenia. And interestingly, he was off treatment for 17 months without progression. And then when progression was noted, he was rechallenged with PT112 and he experienced a second PR. And at time of data cutoff at 10 months, he continued to have that. So I think, really better understanding, what leads to these responses and the duration of response is critical to, developing therapies, either single agent or combination. So thank you.
Thank you so much. If anyone in the audience has any questions for our speakers, please feel free to voice them or submit your questions through the chat function.
Dr. Kim, I actually have a question if I could ask the other investigators. So as everyone here knows, there's a constant battle for resources for clinical studies, keeping them open, especially IITs and rare patient populations at our sites. I just, over the last few years, have you guys come across any strategies for advocating for these studies and making sure these are available for patients, especially when there are competing studies that are accruing, much greater numbers, but really trying to find that niche of advocating for a rare patient population and maintaining that clinical research study availability for those patients.
Yeah, great question. Anybody from the panel want to answer the question? Certainly at our institution, we also sort of struggle with the resources in terms of turnover of the research staff. That has been constant sort of exodus of the members of our team, which put a lot of strain on the system. And then the rare tumors, running clinical trials for rare tumors is difficult because it's rare. Plus, there's sort of if you don't show accrual for a period of certain time, then you may get told that where's your accrual goal here, and then your trial may be shut down. And so I think it's really, we as a field, we need to work together with ITMIG and patient advocacy groups to really help support all the trials that are ongoing, and especially for the trials that are present today, which are really excellent. And so I think we just work as a team, and I think we need more engagement from the pharma, because there's really, really good drugs out there, but then those are not being developed for the thymic malignancies, which I see as a sort of limitation.
And I was just going to add that the study that I presented was sort of the inverse of what you described, Dr. Owen. There was a phase 1 study that was pitched basically to our phase 1 group, and by being aware of the biomarkers that were highly enriched within thymic carcinoma, that's sort of been an opportunity to get patients within the basket arm. But I think looking down the road, if there is a positive signal, right, then you really need to think, what does the path forward look like? And then I think you end up running into many of the same challenges that you've alluded to.
Right. There's a follow-up question for Dr. McAdams. Was dosage continued thereafter indefinitely, and how long? The chat.
I think the question is, after the second recurrence, was he maintained on treatment? And the phase 1 paper doesn't specifically go into details about how long the second treatment was, or how many cycles he got, or how long it was continued, or if it was discontinued. They just noted that upon rechallenging at actually a slightly decreased dosing. So the standard dosing that we're using is the 360 milligrams per meter squared on days 1, 8, and 15 of a 28-day cycle. So this gentleman, when they reinitiated treatment, it was at a 300 milligrams per meter squared every 2 weeks. So we do know that the treatment dose was reduced and the frequency was reduced, but it doesn't specify how long the patient was required treatment, or if he was still on active treatment at time of the data cutoff.
I think we are at the top of the hour. There's one last question about clinical trials performed in the UK. And I think Dr. Nabel's clinical trial is being performed in the United States and UK. Is that right, Dr. Nabel?
That's correct. Yeah, there are 5 sites in the UK. I just looked up. There's a Sarah Cannon in London, Oxford, University College London, the Christie in Manchester, and Royal Marsden in Surrey. So more information on those sites and investigators affiliated can be found on clinicaltrials.gov.
Right. So it's 10 o'clock. So as we come to the end of our session, I'd like to express my gratitude to all the speakers for your time and presentations. And I'd like to thank our audience for your participation and your time. So it's been a pleasure moderating the session. I hope everyone found it as enlightening as I did. And Thank you all for joining us today and wishing everyone a wonderful day ahead.